Okay, what about giving spinal meds? So I'm not going to go over all of this, but having a chart like this is useful. This goes over the dosing for opioids for epidurals. Okay, so a couple of things to note is that if you're dealing with kids, then the dosing of the morphine and the fentanyl is determined by their weight, right? X amount of morphine or fentanyl per kilogram. When you're dealing with adults, weight no longer has a role, and age is the determinant factor. The older the person, the lower the dose. These are morphine doses, these are fentanyl doses. If you're going to use hydromorphone or Dilaudid, then typically the equivalence that's used is 0.02 milligrams per ml would equal 0.1 milligram of morphine per ml. So you can kind of use this and convert it to hydromorphone. As we talked about a little while ago, if you're putting bupivacaine in your epidurals, you want to make sure that when you figure out how much they're using per hour and add it up for 24 hours, that the bupivacaine dose does not exceed 400 milligrams, or for a kid, that it doesn't exceed 0.4 milligrams per kilo per hour. Okay, so using that number, you can just, I just sort of did the math for you here. If you're using, for instance, 0.1% bupivacaine, that would, your maximum would turn out to be 17 cc's per hour. But if you're using, 0.25% bupivacaine, then you can't exceed 6 cc's per hour. So here are some of the typical drugs that might be used in epidurals and the typical concentrations that are mixed into the epidural bag. This is more for practical use, I think. I recommend an epidural, at least until they're off to school. Okay, so where do these medicines work? Well, as we said, sort of our primary site is the dorsal horn. Opioid receptors are primarily in the dorsal horns, and these opioid receptors interact with local anesthetic. So low doses of anesthetic, so low that you're not getting a conduction block, can still potentiate the effect of the opioids in the epidural. So we often are using local concentrations in epidurals, not expecting to find numbness. We don't expect to find a conduction block, but we expect a better epidural because it's potentiating the effects of the opioid in the dorsal horn, as opposed to a conduction block, which is blocking a little bit of nerve root that's in the epidural space. So if the patient has diseases such as COPD, sleep apnea, or other risk for respiratory depression, you'd want to decrease your epidural morphine doses. This is decrease the bolus. If you're going to follow a bolus with a continuous infusion, then your bolus dose would typically be reduced by half. And you got to be really careful if you have a patient on epidural and you're thinking of adding IV or oral opioids and the patient isn't intubated, meaning they don't have a controlled airway. So real caution when mixing opioids from different routes like that. So what are some of the problems that come up? Itch is a big one. As I mentioned, a really high risk is the post-C-section, particularly if it was a spinal injection, but epidural is also high risk. So you can try diphenhydramine or Benadryl, nalbuphine, naloxone drips. Typical dose is 40 mics per hour, can be very effective and usually will not reverse the analgesia from the epidural. It could reverse it if it's IV, but epidural is less likely to reverse with this kind of dose. Nausea is another problem. Droperidol can be used, although it now has a black box warning. Metoclopramide, ondansetron, all of these can be effective for nausea. Sometimes mixing, as I mentioned, drugs from two different categories can give you a response rate of up to 90%. If the patient is showing weakness, then lower the local anesthetic dose, either by lowering the concentration or the rate, and then go back and make sure that they improved, because you want to make sure it's weakness just because of your meds and not because of a complication such as epidural hematoma. Okay, let's talk a little bit about headache medications. Question: you have a 21-year-old college student who presents with migraines happening 2 times per week. She is using over-the-counter ibuprofen and acetaminophen for her analgesia. What is a good choice for a daily medication? A, Fioricet. B, hydrocodone. C, topiramate. D, endomethacin. E, sumatriptan. C, topiramate. I'm going to add a couple of precautions to that. So a prophylactic medicine, such as topiramate or Topamax, is indicated. All the other choices are abortive medicines, and you want to minimize their use. And so all of these others are abortive. But one of the things that you want to check before you give Topamax is the patient using birth control pills because it is possible to reduce the efficacy of birth control pills with Topamax. Okay, 44-year-old female presents with a history of severe daily headaches. The headaches started 20 years ago. At that time, they were 1 to 2 times per month. The headache frequency has gradually increased. She takes 1 to 2 sumatriptans per day, 4 to 8 ibuprofens per day, and 2 to 3 Vicodins per day. She's becoming increasingly depressed and disabled. So let's back up and look at the causes of headaches. So the most common causes of daily headaches: stress and tension, the use of pain and headache medications, because they induce what's called rebound headaches, and the use of caffeine. Caffeine is actually analgesic for headaches, but it has a short half-life, and people can go into essentially caffeine withdrawal by the end of the day and get headaches. A lot of patients will tell you who have morning caffeine every day that as soon as they skip a day, they have headaches. But again, in some patients, they don't even have to skip a day. By the end of the day, they can be having headaches. It appears to be some sort of reaction to your herbal pain medication. Medications for frequent headaches. So for frequent headaches, you want to shift away from the abortive medicines and start using the prophylactic or preventative medications. These are basically beta blockers, calcium channel blockers, anticonvulsants, of which the most commonly used are topiramate or Topamax and valproate. Tricyclics, of which the most commonly used one in this setting is nortriptyline. And there could be an argument to use long-acting NSAIDs. Abortive medicine should be limited to a maximum of 1 time per week. Less is better. Use long-acting abortive agents when you have to, so long-acting NSAIDs. If you have to use opioids, you might consider a long-acting opioid such as methadone in low dose and short term. And you might consider switching to a long-acting triptan if they have to use triptans with any frequency. So you'll see here that Frova or Frova-triptan has a much longer half-life than the others. I am unaware of any data that says that it has less rebound associated with it than the other triptans, but at least theoretically, we would think it should. When I get a headache, I take 2 aspirin and keep away from children, just like it says on the bottle. Okay, so we'll just have a few slides here for our conclusion of this section. So when you're treating pain, our goals are to modulate the ascending pathways. These are the pathways carrying pain from the periphery to the brain. So the small fibers, which are carrying the pain signals, we would like to decrease those by using anti-inflammatories, opioids, or local anesthetics. The large fibers carry non-pain signals, and we kind of think of them, to overly simplify the case, as competitive with the small fibers. So if we increase these with TENS units, physical therapy, exercise, stimulation of the skin, etc., we can reduce pain by, again, competing with the small fibers. Then we have the descending pathways, which are inhibitory. They release norepinephrine and serotonin in the dorsal horn, inhibitory of pain. So we want to make use of those. Again, opioids, anti-inflammatories, tricyclics, SNRIs, anticonvulsants may all help with that. It could be that psychotherapy, stress management, and acupuncture may also help with those. So a case for us to discuss. Larry is a 51-year-old with adult onset diabetes and severe pain and dysesthesias in both feet. He's currently using hydrocodone, 5 milligrams / 300 of acetaminophen, 4 times a day, but with minimal relief. He's complaining of constipation and fatigue. What would you do? So I'm going to shift gears a little bit here and ask you guys to give some suggestions as to what you would do. Membrane stabilizer. A neuropathic med will make it broader. A neuropathic med. Good. Any other thoughts? She's got constipation, so you're going to want to pay attention to that. Either treat it or get them off of constipating meds, or both. Anything else? Decrease the opioids that he's taking per day.
Also make sure his diabetes is tuned up.
Tune up his diabetes. Okay, good job. So consider using a neuropathic pain medicine. Assess if there's coexisting depression, because if there is, that might help you determine which neuropathic med you would probably use an antidepressant. Reduce or eliminate opioid use, which you guys got. Treat constipation on a preventative basis. Good job. So let's do another one of them. Greg is a 65-year-old with metastatic prostate cancer. He is admitted for a flare of pain and nausea. His pain medications at home were fentanyl patches, 25 micrograms, extra strength acetaminophen, 3 tablets TID, hydrocodone mixed with acetaminophen, 2 tabs, 2 to 4 times per day. What would you do? Celiac plexus block. So maybe not for a prostate. That would be more typical for Yeah, so you could consider hypogastric plexus or an impar ganglion block. You could consider those. What else? Consider NSAIDs? Good. So prostate often metabolizes to bone. NSAIDs or steroids are often more effective than opioids are. So it's an acute situation. He's admitted. So your point is that maybe he should use a PCA because PCAs are good in the acute setting. Too much Tylenol. Good pickup. Right? Too much per dose because the third one gives you no added benefit after the first two. Okay, and so he's getting 1,500 3 times a day, 4,500, too much per day also. Too much per dose, too much per day. Pardon? Rescan him? Yeah, you're going to work up what his prostate cancer is doing. You probably also at this point, since you don't know how much for how long he's been doing with the acetaminophen, you should probably check liver functions. So let's look at this. You guys, I think, got it. Oral medications are generally not a good choice in an acute setting like this. The risk of acetaminophen toxicity we talked about. The nausea, the differential should include that pain can cause it and constipation can cause it. So think about both of those. Fentanyl patches are very hard to titrate, so not to be used for controlling acute pain. That doesn't mean you have to stop what he's on, but managing in the acute setting by adding, you're not going to add patches. PCAs, as you guys talked about, are a good tool for titrating. So you might, as we just said, continue the existing patch, or if you are going to take it off and you're going to use a PCA, you would replace the patch with a basal on the PCA. In most situations, if the patient isn't on a chronic opioid and you're going to start a PCA on an opioid-naive patient, we generally would not use a basal. Steroids, as we talked about, can be very effective for the rapid treatment of both pain and nausea. Steroids are very good anti-nausea drugs. I think we got through it. So that completes the pharmacology section. I will